Hello and welcome to the webinar part 1, When Cancer Treatment Causes Menopause, the Physical Impact. I'm Aisha McClellan, Cervical Cancer Program Coordinator at SHARE.
I'm Nefertari Moore, Outreach and Uterine Program Coordinator at SHARE.
Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Cortez finishes presenting, we will begin the Q&A discussion. You're welcome to give comments in the chat section during the presentation, but please submit questions through the Q&A section at the bottom of your screen. When asking questions, please remember that Dr. Cortez is unable to give specific medical advice, so please keep your questions general in nature. I also wanted to mention that closed captioning is available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. This webinar is being recorded and will be available on the SHARE website soon. Before Dr. Cortez begins her talk, we want to share a special video we put together showing the experiences of 4 women who went through medical menopause after their cancer diagnosis.
My name is Miranda Gonzalez, and I was diagnosed at the age of 40 with stage 3 hormone-positive breast cancer. I knew that I wasn't going to have any more children, so when my doctor suggested I had my ovaries removed, I was all for it, because I wanted to do anything possible to reduce the amount of estrogen in my body.
I'm Megan Claire Chase, and I was diagnosed with stage 2A invasive lobular breast cancer. So I was surgically induced into menopause, and that is because my body was intolerant of tamoxifen. It was intolerant of Evista, which is in the same class as tamoxifen, and it was also intolerant of Lupron injection. My medical team was like, we need to surgically push you into menopause because I was diagnosed with invasive lobular breast cancer under 40. It was the best move because I was already at risk for ovarian and cervical. The best course of action in order to receive some treatment to help prevent recurrence was to have hysterectomy and a bilateral oophorectomy. And doing that would help negate getting those other cancers.
My name is Aisha McClellan, and I had a metastatic cervical cancer diagnosis in 2016. My treatment for the cancer consisted of radiation and chemotherapy, and as a result, I went into early menopause.
My name is Nefertari Moore, and today in this video, I'm going to be talking to you about my experience with being surgically induced into menopause. In 2018, I was diagnosed with ovarian cancer and had a surgery called the oophorectomy, which is the removal of one or both ovaries.
Experience with menopause has been minimal, essentially. Outside of losing my periods, I haven't really been able to tell a huge difference. I don't know that I'm any more or less hormonal than I was before, but generally it's just been the lack of periods.
My experience of going through surgical menopause, it was scary because there was a lot I didn't know, and I didn't know of anyone else who had the same type of procedure. My gynonc was able to do the surgery robotically, so it left minimal scarring, but I did not fully realize how much she was taken out. And so it was actually really painful when my body realized, oh, we need to shift. But also I didn't really think about the emotional impact because I was more concerned about the fact that I could not produce any more estrogen because I cannot go through breast cancer again.
Going into surgical menopause, the symptoms hit me like a brick wall. I had no idea. I was completely unprepared. Within days, my mood and my attitude were just really crappy. I was very argumentative, so much so that even my children noticed it and pointed it out.
I want to say within 24 to 48 hours of being in the hospital and after having my surgery, I experienced my first hot flash. I had this intense heat come up from my thighs into my abdomen, shoulders. My face turned red and it was hot, and the intense heat went up to the top of my head. Once I was released from the hospital and returned home, the hot flashes became more frequent and more intense. My surroundings changes. I had to have the windows open all the time, a fan going, and the air conditioning. So, it was extremely cool in my house, to combat some of those hot flashes. Also, I did experience, I had some vaginal dryness in the lower sex drive.
The two biggest issues that I deal with because of my surgery are a lack of libido and osteopenia. So my bones are on the verge of having osteoporosis, which would make me more prone to fractures.
One thing I wish I would have known about menopause is the ability to preserve my eggs. If I wasn't able to use them myself, it just would have been nice to have the option and have that conversation. I haven't really struggled with a lot of hormonal issues that I know that are related to menopause, but just having the conversation about hormone replacement and just more open dialogue about what I could expect after radiation would have been really helpful.
I wish I would have known is that, some things can trigger some of those side effects. For me, my triggers were, taking hot showers. I can no longer take hot showers anymore. Drinking coffee, having chocolate. Those would cause me to have night sweats and or, hot flashes.
You know what I wish I'd been told about? I wish I had been told about this great website called Hister Sisters. I discovered that on my own, and it was through them that I was able to really prepare, at least for that overnight stay in the hospital. I really wish I had known how emotionally I would be impacted by this decision. I was more concerned about just get it out, do what you need to do, because I cannot go through breast cancer again. I cannot go through any other type of cancer again. I was just more about, I just want to survive. And I did not think about the grief that would come, the pain, that anguish that would come. No one told me that, hey, you might want to get some counseling after you do this, or even before you do this, to really prepare yourself of what it's going to be like to not have the parts that essentially make you a woman.
The care team sat me down and talked to me about what to expect once I was in menopause. I was told that once my ovaries were removed, that I would be in immediate menopause. The side effects to look out for would be night sweats, hot flashes, changes in my mood, trouble sleeping, and even some women go through depression and anxiety. We talked about some of the more private things, such as intimacy and sex.
I feel like my treatment team was so eager to get me into treatment that we didn't stop and talk about side effects and what I could expect post-treatment. It was more trying to just get the ball rolling with treatment. And I should have done my due diligence to research questions and outcomes so I could be best prepared for what was going to happen post-treatment.
My treatment team, they told me, of course, I'd be spending the night in the hospital. They would manage my pain. They told me that they would wake me up in the middle of the night and get me walking before officially the next day to make sure I could do that. They did let me know that I would have like these compression things going all the way from my ankle all the way up to my thighs to make sure I didn't get any blood clots. And they told me that when I woke up, I'd probably be in the midst of a hot flash. Well, that didn't happen. I was actually in a cold flash. So that feels more like ice picks. My entire body gets like ice cold and it hurts. It's painful. So that was something I didn't know would happen, and they didn't know that would happen either. And we believe it's because of the nerves in my feet are so damaged that I don't feel heat the way someone normally would. It's like they kind of prepped me on the mechanics of it, right? But not the emotional impact of what I would go through.
I wish my doctor would have mentioned more of the things to expect after surgery, because at the time I was really scared. I was having issues that I didn't know where they came from or how to deal with them. Had I been more prepared on what to expect, I could have probably had healthcare professionals to reach out to already on hand, maybe exercises or tips or any kind of information from other breast cancer survivors on what they had been through.
Advice I want to give to, women going through menopause or about to go through menopause is listen to your body. Anything that is out of the ordinary, I would say to report it to your care team.
My advice to anyone who is considering this type of surgery would be to demand full transparency from your doctor about all of the side effects you'll experience. Had I known that this would have such a negative impact on my bone health, I might have delayed my surgery a few years till I was older.
The advice I would give women who have to go through surgical menopause, especially when you're under 40, is to really make sure that you keep your mental and emotional health first. Try and get some counseling or set up those people around you to support you, because there is going to be grieving, and it's going to be so unexpected, and it's going to be sometimes so palpable, but it might happen a few weeks, a few months after you heal.
Piece of advice: if you're undergoing cancer treatment and you're going to be forced into early menopause, is to just learn about what it is overall and write down questions for your doctor so you can be as best prepared as possible, and definitely explore the conversation of fertility options as well as hormone replacement.
Now I'd like to introduce you to today's speaker. Dr. Cortese is a gynecologic oncology nurse practitioner at Columbia University. Prior to working at Columbia University, Dr. Cortese held a number of positions at the Mount Sinai Hospital, including Associate Director of Cancer Clinical Trials and Associate Director of Oncology Nursing. Dr. Cortese received a BS in biology from Marist College, a BSN and MS Family Nurse Practitioner from Pace University. She received the Mount Sinai CTSA KL2 PhD Clinical Research Award in 2009 and graduated from Mount Sinai. PhD in Clinical Research Program in 2013. Dr. Cortese was the first nurse to graduate from the Icahn School of Medicine at Mount Sinai with a PhD. Dr. Cortese has extensive experience in clinical research, oncology, nursing, and cancer care delivery for over 20 years. She is also a 7-year breast cancer survivor. Her personal knowledge of being a cancer patient has provided patients much comfort.
Thank you so much. Okay, so for today's presentation, I'm going to be going over what menopause is, the different types of menopause and cancer, symptoms of menopause, and the different treatments used to treat the menopausal symptoms. So by definition, menopause is when a woman stops her period for a 12-month time span. There are different types of ways that we can go into menopause, and one is the natural aging process. Another is surgical menopause, such as having a bilateral oophorectomy. and chemical menopause, which could be from different medications, such as chemotherapy, that can put you into a menopausal state. So with breast cancer, patients who have hormone receptor positive breast cancer sometimes go into menopause because they have to receive medications called aromatase inhibitors, which are medications that decrease the estrogen in the body. So if you have a breast cancer, such as myself, that had a hormone receptor positive breast cancer, the treatment is typically something called aromatase inhibitor, which can be something like letrozole or something known as anastrozole or Arimidex. So, but in order to receive those medications, you need to either be on medication in order to stop the ovulation process, or you need to have a bilateral oophorectomy to remove the ovaries, so it puts you into surgical menopause. With ovarian cancer, part of the treatment of ovarian cancer is surgery. And for patients who have ovarian cancer, they will have a bilateral oophorectomy and a total hysterectomy for their treatment. And this reason is to do not only to remove the cancer surgically, but also for staging purposes. For endometrial cancer, patients will undergo bilateral oophorectomy, also a hysterectomy, and sometimes radiation therapy. So the surgeries and the radiation therapy can put the patient into menopause. With cervical cancer, some patients do have a definitive surgery, such as bilateral oophorectomy, total hysterectomy, but sometimes patients will be receiving chemotherapy plus radiation therapy for the treatment of cervical cancer. Just to mention other cancers that do put women into menopause is leukemia and lymphomas. Some patients who have a high burden of disease or have relapsed in the past will go into a stem cell transplant. And those patients will receive high doses of chemotherapy, and which can render them into menopause. So just to touch upon natural aging menopause, really what it is there's a decrease in estrogen and progesterone due to the loss of ovarian follicular function and a decrease in the circulating blood estrogen levels. So when a woman goes through natural menopause, it's very gradual. Usually some of the signs that you can notice is having irregular menses or periods when you're going through perimenopause. Typically, women go through menopause between the ages of 45 and 55 years of age. But there are cases where we need to do surgical menopause. And really what it is, it's having both your ovaries removed. It's called a bilateral oophorectomy. Typically, these surgeries are done laparoscopically. If a patient is having surgery due to a gynecological cancer, and if the cancer is too large, sometimes the surgery will be done open, which means they will put an incision down the abdominal wall and would remove the tumors and any type of female organs out surgically through the abdominal incision. To go over what some of the reasons why patients can get hysterectomies is because they could have a benign disease such as ovarian cysts. Sometimes an ovarian cyst can completely encompass the whole ovary where we can't save the ovary. So patients, sometimes will have an oophorectomy to remove that ovary. I mentioned the gynecological cancers, such as ovarian cancer, endometrial cancer. We will remove the ovaries in those situations. And then risk-reducing treatment in women with inherited increased chance of developing ovarian cancer, such as patients who have the BRCA1 or BRCA2 mutations. So patients who have the BRCA1 or BRCA2 mutations, it's an inherited gene which can cause breast cancer, and also puts you at risk for a 50% chance of developing ovarian cancer in your lifetime. Having the surgery is very important to reduce those risks, especially for ovarian cancer, because there is no good screening mechanism in order to catch ovarian cancer at an early age. Also, I wanted to just talk about sometimes patients will also opt to have a bilateral oophorectomy in cases of such as breast cancer. I had done this myself. I decided to have a bilateral oophorectomy and a total hysterectomy because I wanted to reduce the chances of having any estrogen in my body and preventing recurrence of disease. Some patients choose to do that. Some patients choose to receive the injections, which I'll talk about in the next slide, on how that can also put you into menopause temporarily. So chemical menopause is something that is temporary and reversible menopausal state, and it's created with the use of called a gonadotropin releasing hormone analog. And really what it is these types of drugs act on the pituitary gland in the brain to suppress ovarian and ovulation and ovarian hormone production. I'm sure many of you have been on Lupron injections or Zoladex injections. These injections are typically given monthly to help suppress the ovarian function and the hormones. And I've also seen them given every 3 months. However, the efficacy with these injections actually leans towards more having the injections at a monthly interval. So menopausal symptoms. Some of the common symptoms we get through menopause, and I can tell you I've had every single one of these, and I can tell you how, from a medical scientific standpoint, what are the treatments of them, but also from a personal experience on how I manage these symptoms. One is amenorrhea. So what it means is not having any periods anymore, and that happens definitely when you have surgical menopause, or if you're using Lupron or Zoladex to shut down the ovarian hormone production. Vaginal dryness, that is another symptom that can happen. What happens is there's no more estrogen in your body, and your vagina ends up becoming very atrophied, which means the walls of the vagina are very thin and they become very dry. There's hot flashes and chills that can happen. I could tell you particularly that I used to, especially when I was undergoing chemotherapy, I ended up having a lot of hot flashes and chills, and the chills would come first. And then about 8 minutes later, I would get a very horrible hot flash afterwards. This kind of continued. It got better after chemotherapy for me, but when I had my surgery, I had my total hysterectomy and bilateral oophorectomy done. I still had a lot of hot flashes and the chills. But I can tell you that this has been 7 years now for me, and these hot flashes had definitely gotten much better. I can't say I don't get them anymore, but I can say that they have diminished, I would say by 95%. The night sweats and sleep problems. Well, if you're having those night sweats at night, having hot flashes at night, you're definitely going to have some inconsistencies with your sleep. Patients can develop insomnia from it. There are some recommendations, with these night sweats. There are certain pillows you can use, or certain types of blankets can help as well. I definitely, encourage you to look into those. They can be very helpful. There's also mood changes. I can tell you, not only from having a breast cancer diagnosis, but also going into menopause, my mood drastically changed. I became very depressed, and I had an increased amount of anxiety. And I don't think it's just due to having the diagnosis, but this can also be due to having menopause. Weight gain and slowed metabolism, absolutely. Unfortunately for myself, I had gained a lot of weight after I completed my chemotherapy and my radiation therapy and had my surgery. And I gained close to 70 pounds, which I can now tell you that I have completely lost, which I'll talk to you about that a little in one of the later slides and how I did that. Thinning of the hair and dry skin, absolutely. My hair is much thinner than what it was prior to even having cancer. My recommendation for that is to definitely see a dermatologist where they can kind of investigate what is causing the hair loss. Sometimes it can be something as simple as a vitamin deficiency. Also, it could be something just due to stress. But definitely if you're having hair thinning of the hair, and it can be sometimes very upsetting to see on yourself, I highly recommend that you see a really good dermatologist. So amenorrhea and fertility. So amenorrhea, as I said before, is the absence of menstruation, not having your periods, which can happen when you go through menopause. Also, one of the other things that unfortunately happens is that when we go through menopause, we also have infertility. When I was diagnosed at age 36, I had one daughter. She was at the age of 3 when I was diagnosed, and I was also planning on having a second child. Right before I got diagnosed with breast cancer, I went through all my I went to see my gynecologist. I made sure that I was taking my prenatal vitamins. And the last thing that I was going to do was to get my annual mammogram because I have a family history of breast cancer. So that mammogram showed that I had a mass, and I was diagnosed with breast cancer. Within a few weeks, I ended up having a bilateral mastectomy. And instead of going through any type of fertility preservation, I felt that it was more important for me to go through straight to chemotherapy as soon as possible. Looking back upon this, would I have done things a little bit differently? Maybe. I didn't really have so much of a conversation with my oncologist about fertility preservation, but I definitely think that anybody who's premenopausal and wanting to have children, they should really consider seeing a reproductive endocrinologist before going through chemotherapy. Some of the other things that can cause this infertility is not only just chemotherapy, but also radiation therapy. Like as I had mentioned, if you're having pelvic radiation therapy due to, say, endometrial cancer or cervical cancer, that could absolutely make you infertile. The surgery, as I mentioned previously, and then of course, endocrine therapy. So those patients that are receiving the Zoladex or the Lupron and have to take an aromatase inhibitor, unfortunately, it is not recommended that you try to get pregnant during you're taking an aromatase inhibitor. So you would have to come off the medication and then try to become pregnant, but at the cost of possibly having recurrence of your breast cancer. Those are very difficult decisions to have and difficult discussions to have. That's something that you really need to speak with your oncologist about, and really discuss the risks and the benefits of possibly doing that. I believe there is a study going on looking at this called the POSITIVE trial, looking at the temporary suspension of using endocrine therapy, of stopping endocrine therapy, and seeing if women could conceive and then go back on their endocrine therapy after they have a child. But definitely, those are things that you really need to speak with your physician about. Fertility preservation. So as I mentioned before, right after diagnosis, before you start chemotherapy, you should really speak with a reproductive endocrinologist. And your oncologist should be able to provide you any type of referrals to and who to see for reproductive endocrinology. Some of the methods are egg freezing, embryo freezing. Those are possibilities. If you choose not to do fertility preservation, there are options such as adoption and surrogacy. So moving on to the symptoms of menopause, as I mentioned before, there are hot flashes, cold flashes, night sweats that can occur. So what are some of the strategies that I use with my patients when they complain about hot flashes? The first line of treatment that is recommended for patients from a pharmacological standpoint is using a drug called venlafaxine, which is also known as Effexor. This medication is an antidepressant. However, it can help with reducing the amount of hot flashes. The literature also shows that using a medication called gabapentin or Neurontin may also be helpful on reducing the hot flashes. Weight control, healthy weight is a very important. Healthy diet. I can tell you that when I was 70 pounds heavier than what I am today, I was having actually more hot flashes. Now that I have lost my weight, I can tell you it's gotten much better. So definitely, if you are overweight, that's really something to consider, is to really have a healthy diet and incorporate exercise. Also, cognitive behavioral therapy is helpful. They can help you on how to relax and do deep breathing, especially when you have going through a hot flash. Sometimes that is helpful because complementary and alternative medicines such as acupuncture, hypnosis, and yoga and relaxation. The genital urinary symptoms that occur because of menopause is vulvar, which is the outside of the vagina, and vaginal atrophy. So as I mentioned before, vaginal atrophy is the thinning of the vaginal walls. This can cause vaginal dryness, dyspareunia, which is painful intercourse, irritation of the genital skin, pruritus or itching, burning, vaginal discharge, soreness, and also the psychosocial effects. So when you go into menopause, you can have a decreased libido. And of course, having changes in your body image. So undergoing a bilateral mastectomy can sometimes, you might not feel comfortable in your own skin, and it takes a long time to really accept the way that you look. I have gone through that personally, and you really have to listen to your body, and really you really start to, after a while, accept the way that you look. And sometimes therapy, cognitive behavioral therapy, is also helpful in helping change your image of yourself. Also, there is the pharmacological strategies that we use to treat these symptoms, and vaginal lubricants and moisturizers are typically the first line treatment that we use. There are water-based lubricants such as Replens. I tend to recommend my patients to try hyaluronic acid moisturizers such as Reverie or Hylo-GYN. With the Reverie, it is a vaginal suppository, and you use it 3 times a week. Patients state that this is very helpful for them. So I do recommend that you look into this if this is something that is a problem that you're dealing with. The Reverie is found on the internet, so you could just search Reverie and you'll be able to look up and order that type of vaginal suppository. These suppositories do not contain any type of estrogen, and these are safe to use if you're if you have breast cancer. Also, vitamin E suppositories. And then the literature actually has also shown that if you use lidocaine at the vulva area, so if you're having having a lot of pain during penetration, that you can use some lidocaine in the vulvar area to see if that helps with the pain, the discomfort. The non-pharmacological strategies, the cognitive behavioral therapy, healthy diet, smoking cessation. Yes, smoking can definitely, cause more atrophy in the vagina. And if you do smoke, not only just for reducing your risk of recurrence of cancer, but also to help with any type of genital urinary symptoms. Physical exercise is also very helpful. And the vaginal dilators. So the vaginal dilators is really for patients who have a very narrow vaginal canal. So especially patients who've gone through radiation therapy in the pelvic region, there might sometimes be some narrowing of the vaginal canal. Definitely, it's something you want to speak with your physician about. You can get vaginal dilators through Amazon and things like that, but those are definitely something that you want to speak with either your radiation oncologist about or with your GYN oncologist about using. So the vaginal CO2 laser therapy, also known as the Mona Lisa touch. So this type of therapy really is called a vaginal rejuvenation. What it is it's a procedure where they're using laser inside the vagina and also outside the vagina to help rejuvenate the vagina and reduce any type of atrophy. It usually takes 3 sessions, about 6 weeks apart from each session, and there is maintenance that you have to do annually. This is not covered by insurance, and this can be a very expensive procedure, and also we don't have enough literature out there, not a lot of research to show is this truly effective in reducing any type of atrophy for patients who have any type of gynecological cancer or breast cancer and have been and are in menopause. They also mentioned, the literature has mentioned complementary and alternative medicines such as acupuncture may be helpful for any type of pain. That's something you may want to look into, but I would definitely say that your first line of therapy is definitely to try something from a vaginal lubrication or a vaginal moisturizer. So to try that first. So unfortunately, with menopause, there is the symptoms of osteoporosis, and what it is, it's a decrease in your bone density, about 2.5 standard deviations less than the peak bone mass. So as you can see in these photos here, there's much more bone mass in the normal picture than there is in the osteoporotic picture. So having more of those holes, as you can see, really puts you at higher risk for fractures. So it's important that you get your bone densities done, which is typically done every 2 years. And if you do have osteoporosis, you speak with your doctors about what are the best treatment options for you. Fortunately, osteoporosis really has no symptoms. Some of the strategies that we use to treat osteoporosis or even prevent it is something called bisphosphonates, or called zoledronic acid, or Zometa can be used, or denosumab or Prolia. So I'm going to just talk about this a little bit, especially for the breast cancer patients. These 2 medications are given to patients not only to prevent osteoporosis, but they can also be used to prevent bone metastasis. They're typically given once every 6 months. Some doctors do it every up to 3 years. I've had, my oncologist has given me Prolia up to 5 years. This is definitely a discussion you want to have with your oncologist about to see if these medications are appropriate for you. As well, the non-pharmacological strategies, you want to definitely take your vitamin D and your calcium. Getting your vitamin D levels are very important. You definitely want to make sure that your vitamin D level is above 30, which is the normal level. I know some oncologists have recommended keeping your vitamin D level around a 50, but definitely taking vitamin D is very important and making sure that your body absorbs it. That's why we do check the levels. weight-bearing exercises. So doing strength training or weight-bearing exercises to keep those bones strong is really important. Having a healthy diet, including protein in your diet. And of course, smoking cessation. So if you do smoke, you're much more high risk for developing osteoporosis. And I highly recommend that you do think about quitting smoking if you do smoke. Cardiovascular disease is also another risk factor or higher prevalence in patients who have menopause. And what happens is if you have these cardiovascular risk factors, these can, cause much more at risk for things such as heart attack or stroke. So one thing is the central adiposity. And what that is having fat, abdominal fat. So when we're younger and we're premenopausal, women tend to have their weight mostly in their hips and thighs. But as we get older, that tends to shift to more of the abdominal region. But women who have considered an apple-shaped body, they say that they're at much more higher risk for having a cardiovascular event or disease. Also having high cholesterol. You want to make sure your cholesterol levels are normal. Having glucose intolerance is another risk factor. Having hypertension and fatty liver disease. Some of the non-pharmacological strategies you can use to help prevent this from happening or help reduce any of those risk factors is definitely following a Mediterranean diet. That's really a diet full of fruits and vegetables. Having regular exercising at least 30 minutes a day for 5 times a week is very helpful. The smoking cessation, the alcohol restriction, so making sure that you're not drinking alcohol every day. It not only does it increase your risk for cardiac events, but also increases your risk for developing cancer as well, or recurrence of cancer. So, and you want to keep your blood pressure less than 140/90. So musculoskeletal symptoms are definitely a side effect of menopause, especially for the patients that are receiving those aromatase inhibitors that I mentioned before. And those aromatase inhibitors, such as letrozole or anastrozole, can exacerbate these types of side effects, such as arthralgias, which is joint pains, myalgias, which is muscle pain, arthritis, and tendinitis. Some of the pharmacological strategies we use to help with this joint pains and muscle aches that we have is using something called duloxetine or Cymbalta. I also want to point out that Cymbalta can also be used to help with hot flashes. So if you're having not only joint pain, but also hot flashes, this may be an appropriate medication to take, but something definitely that you want to speak with your oncologist about. And also they recommend vitamin D can also be helpful. So I think actually probably the most helpful thing for me with my joint pains is going through aerobic exercise. What I do is I actually do spin cycling, and I find that to be the most helpful because there's less impact on my knees compared to, say, running. I find it to be not only helpful just for my joint pain, but also for my mental state as well. I feel less anxious when I'm using spin cycle, and I feel that my mood is more elevated. So, as I mentioned before, that going through menopause can also affect your mood as well. And then acupuncture can help with the joint pain as well. And then yoga, especially strength stretching, can actually help with any type of joint pain or muscle aches that you're experiencing. And then, unfortunately, as a breast cancer patient, when you've gone through, everything, surgery, chemotherapy, radiation and even going through menopause, unfortunately, sometimes we get the weight gain. And weight gain can cause definitely a poor cancer prognosis. So women who are heavier, who have more, have obesity, tend to have a poor cancer prognosis. Also, having weight gain can cause comorbidities such as hypertension, high cholesterol, diabetes. You can be more fatigued from the weight gain. You can have a more functional decline, and then, of course, decrease in quality of life. So interventions for a healthy weight are physical exercise, can definitely help with that healthy weight. Healthy diet can be helpful, and cognitive behavioral therapy. If you are dealing with a lot of weight gain after after going through menopause, I do recommend sometimes seeing an endocrinologist just to rule out any other types of reasons that could cause the weight gain. It could be a thyroid problem. It could be more metabolic problem, but definitely, I would, not lose hope and really speak with a endocrinologist to see if there's anything that could be helpful for you to help with the weight loss. Some patients that have severe obesity or have morbid obesity, there are clinical trials going on right now, and they're looking at seeing if a sleeve gastrectomy can actually reduce the risk of recurrence in breast cancer patients who are morbidly obese. Those trials, I believe, are just starting, but definitely more to come on that when the studies have completed and the results are provided to the community. So I believe that is the end of my presentation. I just want to tell you what we've reviewed today. We've gone over menopause, defining menopause, types of menopause, menopause and cancer, symptoms of menopause, and treatments for menopausal symptoms. And I'm open for any questions.
Thank you. So now let's start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to get to all of them because of the time constraints. First question we have is, what can I do to ease medical menopause symptoms, and are there any preventative things I can do before surgery?
Okay, that's a good question. So what can we do before surgery? Really being in good shape, having a healthy diet, exercising beforehand. Those, I think, are definitely something that you can do to see if you can limit the type of menopausal symptoms that you could experience after having surgery. Usually we don't give any type of medications like prophylactically to prevent menopause, but just being in a good, healthy weight and having a healthy diet can really help. I could personally tell you that that absolutely has helped for me.
Okay.
So this next question, for some reason, I'm sorry, my video, it won't allow me to turn on again. I don't know what's going on. But this person is asking, what can one do to get their libido back?
Okay, so really with things concerning libido, I find that going through cognitive behavioral therapy is very helpful, especially for patients that are having difficulty with sexual intercourse, that it's very painful. Going through the cognitive behavioral therapy can not only help with any type of depression or anything or anxiety that's going on, but also talk about other ways. Even you could have a session with your partner to discuss intimacy. Sometimes, when we go through menopause, we don't, and going through breast cancer, we don't feel as intimate as we used to be. But going through cognitive behavioral therapy and even going through couples therapy can be extremely helpful for that.
Thank you for that.
Thank you. How can I best manage side effects such as hair loss, night sweats, brain fog, fatigue, and joint pain?
Okay. Hair loss. So definitely you want to make sure you're taking your vitamins, your multivitamin, get your vitamin levels checked as well. So sometimes if you're lacking any type of vitamin deficiency, sometimes you can have hair loss from that. So my recommendation is if the thinning of the hair is really bothering you, I would definitely see your general practitioner or see possibly a dermatologist to determine what is causing the hair loss and if anything could be helpful to treat it. With the hot flashes, as I mentioned before, you can use pharmacological strategies such as Cymbalta or Effexor. I find those that they're very helpful. With the Cymbalta is kind of a 2-in-1. You get not only does it help with your hot flashes, it also helps with your joint pains as well, and also can help with your mood.
This question is that was submitted live, and this person is asking, are there any digestive issues associated with menopause, such as constipation?
Typically, I really haven't had too many patients, or even in the literature, it really doesn't mention too much about any type of GI issues per se. However, if the patient is having any type of constipation, definitely, consider going on a bowel regimen, such as, increasing your fiber intake, possibly taking a stool softener if, you are having difficulty going to have a bowel movement.
Thank you. Appreciate it.
What can I use to treat vaginal dryness?
So my go-to with my patients is actually Reverie. I find that to be extremely helpful. You can use the Reverie 3 times a week. It's that vaginal suppository that will help with the vaginal dryness. And during intercourse, you're definitely going to want to use some type of lubrication. So using both those things can definitely be very helpful for any type of vaginal atrophy or dryness that you may be experiencing.
For those of us who are medically induced into menopause, can there be any negative long-term effects that we should be concerned about?
I would say that, it would be just the standard menopausal type symptoms, and also the increased risk for cardiovascular disease, while you're on that. I don't think there'd be anything different from being in the medical menopause, such as getting the Lupron or the Zoladex. The only thing is with the Lupron and the Zoladex to remember is that it is reversible. It is only temporary.
Appreciate that answer.
So does surgical menopause increase the risk of other health issues?
So with being in surgical menopause, so if you're having, it really depends on the age. So if you're premenopausal, you do have a higher risk of developing any type of cardiovascular disease or osteoporosis. When you're postmenopausal and like going through natural menopause, it's not as abrupt, and you still have the menopausal symptoms, but it's not as a high risk as if you are getting the actual surgical menopause in premenopausal state.
We have another live question, and this person is asking, when should the first bone density test be done, and are these tests routine?
I could tell you right now that if you have the bilateral oophorectomy, absolutely, you're going to get your baseline. I would say within that month or 6 weeks after having your surgery, I would get your baseline bone density. Doesn't matter what age you are. And then they're every 2 years, and this is routine. So definitely your oncologist or even your PCP could definitely be ordering these bone densities for you.
This is another live question. Do you know anything about geographic tongue from hormone changes? And is the presence of a consistent bad taste in my mouth hormonal?
Not so much have I heard that. That would be very rare. I haven't really heard that before. It also, I mean, I'm not sure if the patient is also taking any types of medications, but sometimes the medications we use for breast cancer can cause sometimes a different, like a change in taste, but not from menopause directly.
And then, so is there anything that we can do to help us, like, you know, sleep better at night in terms of like insomnia and with the night sweats?
So with the night sweats, you can do a pharmacological strategy where we could use the medication such as Effexor, which can also help. There's things like the cooling blankets or the pillows can be very helpful to use. And if you're having insomnia issues, I mean, that might be something where you might want to discuss it with your doctor if it's, going on one of these medications would actually be helpful. But those are kind of what my go-tos usually are, is either using the blankets or prescribing the medications such as the Cymbalta or the Effexor.
You mentioned a medication called Reverie.
Mhm.
Is there a lower cost alternative to that?
Yeah, I know it's very expensive. You can use the Hylo-GYN. That might be a little bit cheaper. That's also sold over the counter. I'm sorry, on the internet. That may be a little bit cheaper. Some patients, actually, a physical therapist that had worked with me, had done pelvic wall therapy. She had mentioned that even using something like coconut oil can sometimes help, or the vitamin E might also help as well. That might be something that might be a cheaper option. Also, if you have a compounding pharmacy that's near you, sometimes they can create like a vitamin E suppository with the hyaluronic acid together. I'm not sure if that would be cheaper, but that could be another option. And you could possibly put that through like one of your like FSAs, or I'm sorry, the HSAs, as they call it.
I think we may have time for one last question. And this is another live question. And this person is asking, does vaginal dryness and hot flashes get better over time?
Yes, it does. It does. Okay, so I can personally say that after 7 years, it does get better. The hot flashes, I told you that it's gotten 95% better after all this time. And the vaginal dryness, I would agree too. I would say that it does improve. But the thing about it is that you really have to be vigilant on making sure you use your moisturizers and also the lubricants, because those are going to be so helpful and preventing any of the dryness from coming back. But it does definitely get better.
Good to know. Thank you for that information. So we've come to the end of our program now. Thank you, Dr. Cortese, for an informative program. And thanks to all of you for participating and submitting your questions. Make sure to check out our upcoming educational programs and support groups. Make sure to follow us on social media as well. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. And this concludes our webinar. Thank you. And everyone have
Thank
a
you
good
so much.
day. Rest
Thank
of day.
you.
Bye.
Bye-bye.